Hello, and welcome to the 2026 ICD-10-CM Guideline changes. And before we get into those specific changes, I want to show you how to get to the guidelines. Now, these are the guidelines that take effect as of October 1st of this year, and they stay in effect until September 30th of 2026. You go to cms.gov, then when you get in the search area, put in 2026 ICD-10 CM Guidelines. What you'll find here are not only those guidelines, but you'll also see guidelines for PCS, so they're very, very helpful. So let's go ahead and click on the official guidelines, and you can see the date range and that it's updated as of October 1st. Narrative changes are in bold text. Now, that is what I am going to be focusing on for this little video. Narrative changes. I'm not too worried that if stuff was moved from a prior version, which happens with the underlined part, or the fact that there have been changes to heading titles. I'm only really interested in the bolded text to see what has been changed there. Now, instead of scrolling through this rather long set of guidelines and giving either you or myself a headache, I put them in a PowerPoint, essentially just copying the changes so I can explain them to you. So let's go to that PowerPoint. Yes, I'm doing it that way. 2026 ICD-10 guidelines. I didn't put an agenda page down. I'm just listing those guidelines. Now, the changes start on page 9. I didn't put page numbers on everything, but it shows you where I began. This first one is on commas, and it's right next to the parentheses and the bracket area. This one is just telling you, and I'm going to try not to read these because it's just going to get boring. It tries to say that look at the context in which the comma is being used because it can be index entry, alternate verbiage, a modifier, a possibly and or situation. So when you see commas, look at the context of how that comma is being used. This one, it has to do with somebody other than the patient's provider documenting in the record. And you can see some of the instances where that would happen. You've got a body mass index. That would be a dietitian. Chronic ulcers could be through nursing care. And all the way at the bottom, it says firearm injury intent. That is new this year. So they added that as another thing that can be documented other than the patient's provider. My guess would be a firearm injury intent would probably be documented by somebody in behavioral. If somebody is seeing a counselor and they're saying that their intent to use a firearm. So let's continue on. This one, in a nutshell, and I may have to read a little bit of it to try to articulate it good for you. It's saying that if there are chapter-specific guidelines on how to code multiple use the chapter-specific guidelines. However, when there are none, it says assign codes describing specific sites individually when documented. So if you see no chapter-specific guidelines on how to handle multiple sites, separate them out. Okay? So let's continue on. Now we're going to get into those changes that have occurred per each one of the chapters, and this is chapter 1. And the first thing they talk about is HIV. Now, I will show you in a moment. Let me go ahead and explain these. This isn't really new. It looks to me like it was rewritten to further explain things or make things explained a little easier to understand. The first part of this is saying that if somebody comes in with an AIDS-related illness, like Kaposi's sarcoma, you would put B20 first. Now, B20, of course, is the HIV code. So if anybody comes in with an HIV-related disease, B20 gets coded first. But let's say this person is HIV positive and they're in the ED because they were cutting a bagel and they sliced their hand open. You would still include B20, but slicing one's hand isn't HIV related. So that would come first, followed by the B20. And the last one has to do with asymptomatic HIV. Test or similar terminology is documented and there's no documentation of symptoms. It tells you to use Z. Now, is this stuff new? No, it's not. It's rewritten. I want to show that to you right now. I'm going to take you to my actual online book so you can see the guidelines for this particular HIV section. And here they are. So when you look at this, patient admitted for HI-related condition, it tells you the principal diagnosis should be B20, HIV disease, followed by additional diagnosis for all reported HIV-related conditions. And then a little bit further down under B, if a patient with HIV is admitted for an unrelated condition, so that unrelated condition comes first, followed by B20. Now, they also include the asymptomatic, that's under D, Z21, asymptomatic HIV. Infection status is applied when the patient without any documentation of symptoms is listed as HIV positive. So as you can see, it really hasn't changed. It's been rewritten. And I would make the assumption they're trying to make it clearer for everybody to understand. Here is the next slide. It's still dealing with HIV. I won't flip back to the other guidelines. We'll just stay here. I'm sure you understand about it being rewritten for clarity. This first one here is if you wind up with an inconclusive test that you really can't tell if the person's HIV positive or negative, you should assign R75, inconclusive laboratory evidence, and it says of HIV. Now with G, if somebody has ever been diagnosed with, with an HIV-related disease, they will always be coded with B20 first. Okay? You should never be assigned R75 inconclusive laboratory evidence, so it's showing you there, or Z21 asymptomatic. So they could have an HIV-related disease and actually be able to get cured from that disease or maybe have it go into remission. That doesn't take away the B20 as far as it being set in as the first diagnosis code for that patient. So let's continue on. With this next set of guidelines, it's dealing more with pregnancy, and it's showing you right there. When you have a pregnant lady, the actual Chapter O codes come first. They have precedent over all other chapter guidelines. So in this case, we have a person, and if she is HIV positive or has an HIV-related disease, in this case, you have to sign O98, HIV complicating pregnancy, followed by B20. My guess is the B20, it's because it's such a known code that it's easy for somebody to understand that this pregnant lady does have HIV. And then it's showing you down below, if they're asymptomatic, you assign a category or a code from subcategory 098.7 followed by Z21. So in this case, you're still doing the O code because they are HIV related or HIV positive, my error, sorry. And you're following that with Z21 showing that they're asymptomatic. We're still within Chapter 1, still looking at the HIV guidelines. The first one we're coming across is without signs or symptoms is being tested for HIV, assigned code Z11.4. Encounter for screening for HIV. And right below that, if a patient with signs or symptoms of HIV presents for HIV testing, code signs and symptoms. An additional counseling code of Z71.7 would be used. A little further down from there, you have Z11. Encounter for screening for HIV should not be assigned if HIV signs or symptoms are present when a patient presents for follow-up regarding their HIV test results. So if a person comes in and the test is negative, you can assign Z71. If a patient has positive HIV status but is being managed by medications, you would assign Z21, asymptomatic HIV infection status, because you don't have honestly anything else that could possibly work in this instance. Now we're going to look at Chapter 2. This next guideline is looking at individuals who have to come in for chemotherapy, immunotherapy, or radiation therapy. And it's showing you that if they're there for neoplasm, assign Z51 encounter for radiation therapy, or Z51 for chemotherapy, or Z51.12 for antioplastic immunotherapy. And as the first listed, so yes, it is true that they have cancer, and you would think that cancer needs to come first. But when they're coming for chemotherapy or one of these therapies, that therapy comes first. If you have AAPC books under Chapter 2, they have a wonderful chart there that lists the different scenarios. If they come in for anemia, you put this first, then that. I would suggest you taking a look at that one. And if they're using more than one type of therapy, code Z51 and codes from the subcategory Z51.1, they can be assigned together. So let's continue on. Now we're going to look at Chapter 4. And yes, it does kind of skip around a little bit because there aren't changes within every single chapter. So in Chapter 4, I personally wouldn't have thought of this, but my father-in-law actually had diabetes, and my mother-in-law put him on a really strict diet and got the weight off of him, and now he no longer has diabetes. So in case of him getting coded for anything, they would probably use this one, and it is brand new because I had not seen it in previous editions. Type 2 diabetes mellitus in remission. Can type 1 ever be in remission? No, afraid not. Remember, type 1 is autoimmune. More than likely, the pancreas isn't producing any insulin or very little insulin. So there's going to be no remission there. It's just not producing. Type 2 is insulin resistance. So it is possible for the reversal or the remission. Code E11.A, type 2 diabetes mellitus without complications in remission. So this is a new one, and it's actually nice, in my opinion. So let's continue on. Now we're looking at Chapter 9. This is a big one. I believe I've seen the first one before, so it may be just a rewriting of that guideline. They're saying hypertension with heart conditions classified to I-50, heart failure, I-51.4, myocarditis, I-51.89, other ill-defined heart disease, and I-51.9, heart disease unspecified, is assigned a code from I-11, hypertensive heart disease. Use additional codes from I-50 for the heart failure or I-51 for any complications or ill-defined description of heart disease. So as we look at the second one, hypertension with heart conditions classified to I-51. Myocardial degeneration, or I-51.7, cardiomyopathy, is assigned to a code from category I-11, hypertensive heart disease. No additional code is assigned to identify the specific heart condition. So in this case, if you have I-51 or I-51. You don't have to worry about adding in stuff for the heart failure end. The same heart conditions, and they have them listed, and they're showing, pardon me, with hypertension are coded separately if the provider has not documented that they're unrelated to hypertension. The applicable hypertension code I-10, essential primary hypertension, or a code from I-15, secondary hypertension, should be assigned. So if you're working within a cardiologist office, this is something you most definitely would be interested in. Now, when you have hypertensive heart disease and chronic kidney disease, you have codes from I-13, hypertensive heart and chronic kidney disease. They're combination codes that are used for hypertension, heart disease, and chronic kidney disease. Now it's also telling you to assign codes from I-13, hypertensive heart, and chronic kidney disease. You'll more than likely also have to include the stage of the chronic kidney disease. So that would be N18 if memory is serving correctly. So from chapter 13, this is similar to what we were talking about before. Code describing specific sites are signed individually by site when documented. When specified sites are not documented, you have to sign the appropriate code for multiple sites. Body mass index. I do believe this one is new. I don't recall seeing it, and I'm not going to take up your time searching through my current books. What they're saying here is that you should not put in BMI codes unless the person actually has obesity or possibly anorexia documented by the provider. Then you would be including those BMI codes. Now, if you have a pregnant lady, no BMI codes. What's below that one has to do with homelessness. So remember, we have the SDOH codes in chapter Z. You should, if they're homeless, be assigning a code from Z50.0. And you may not think, Z, why? You're giving a very appropriate picture of the patient's condition. If they're homeless, how are they going to take care of themselves? Items like that. And in some instances, those E-codes are reimbursable. So you're not only improving the care of the patient, you're also improving the revenue of the facility. And I want to thank you for sitting in this, I would say short, but it's a little longer than I really wanted to go, talk about 2026 ICD-10-CM Guidelines. Thank you. I hope to see you soon.